fourth town hall of our community health community health town hall series. It's early on a Saturday, right? But we're glad you're all here. Today we're going to be talking about substance use disorder, the longest pandemic. And I think for me, this is one of my, it's a really important topic because I think there are so many misconceptions and so many myths about addiction and substance use. And so we're hopeful that today we're going to be able to kind of hopefully dispel some of those myths, maybe answer some of your questions if you have them, which we hope you do, and have a really engaging, respectful dialogue on this subject. It's a tough one sometimes to talk about. I just want to remind folks that, substance use, this is one of the myths. Substance use is not a moral issue, and the myth is that it is, and it's just not. And I also, want to say that, and we'll learn this today with our panel, so grateful to have them here, that substance use does not discriminate. It doesn't care if you live on a hill and, with a lot of money or if you live on the street. Substance use doesn't care. And so really being able to look at how we can better understand our friends that are struggling and offer up supports to them. That's why we're here, to kind of dispel those myths. So with that, I just want to, again, welcome you for being here. We have people tabling outside. There's a lot of great stuff happening out there. We have food, coffee, lemonade, and we just really appreciate your willingness to be here and to talk about this really super important conversation that affects all of us, whether we have experienced addiction ourselves or whether we have a child or a family member or somebody. We all know somebody that has been addicted at some point. So mostly. So with that, I'm going to turn it over to Jacob Rosen, who will be moderating this event today. Thank you.
Hello, everyone. My name is Jacob Rosen. I'm the managing clinician with Humboldt, with the city of Eureka for Crisis Alternative Response. Just a couple things. Want to say some thank yous. Thank you to Humboldt County Behavioral Health for collaborating with us on kind of continuing to push these events forward. That's been a huge support. Also want to thank Eureka Police Department for being present today. Also would like to thank Dell Police Department for lending us Chief Allen on our panel. It's what, a seventh of their police department. So it's a big deal getting to have Chief Allen up here today. That's super, super important. And he's a excellent expert on these topics. Also, I'd like to thank Crossroads, the VA, NAMI for being here. I'd like to thank Providence St. Joe's and Raphael, who's tabling out there. Aegis for being here. Eureka Natural Foods donated some of the food today, so thank you to them. And the Flower Boutique for our wonderful arrangements up front. And then I'd also like to thank our amazing city team that has, continued to work really, really hard to put this event together over this year. One big announcement, we were going to have Dr. Byan from Waterfront Recovery here today. Unfortunately, she's sick and couldn't make it. And, last minute couldn't find a replacement. So that's a bummer. For those of you who don't know, Waterfront Recovery Services is our only medical detox and rehab in the area. We have other substance use treatment facilities, but as far as the medical component, that's kind of the only one in the region. And they do wonderful services there. They provide dual diagnosis, culturally sensitive, trauma-informed treatment, and really offer an amazing array of services. If there are any questions specifically for Waterfront, if you submit them with a note card, then I can get them to Dr. Byan, and maybe we'll do like a short video recap after the event. Some procedural stuff. We are going to have a break at about noon. We are a little light on audience, and so if things are not, if things are winding down at some point, then maybe we'll have a break at that point, and we'll kind of just play it by ear. I also want to invite folks, if you don't feel comfortable coming up to the microphone, there are note cards on the left table over there, and you're welcome to write in your questions so that we can read them anonymously. We recognize not everyone wants to come up and be on camera. As far as rules go, please be respectful. And if we're kind of, I hope that that's not an issue today, but if it is, then, I may end up interrupting just to kind of get us back on track. And so without further ado, I'd like to have our panel introduce themselves and kind of talk about who they are and what they do.
Hi, I'm Wes Harrison. I'm Executive Director of North Coast Substance Abuse Council, more affectionately known as Crossroads. We are a 20-bed facility on Myrtle. We've been operating since 1975 out of the same location. We are a 3.1 residential level of care, which means we are low-intensity medically managed. We are partnership funded. We are part of the DMC ODS waiver, which brings and funds treatment to our regional model. We are a compassionate care center. We believe in doing things a little differently, treating the whole person and having a multitude of services in a community-based environment, one that mirrors society, so that way returning to our community isn't a shock. We promote family support, relational support, cultural support. We are trauma-informed and we are evidence-based, state licensed, and we are definitely in need of expanding because 20 beds is not enough.
Thank you.
Thank you. Yeah. My name is David Villasenor. I'm a psychiatrist at the Eureka VA clinic. I'm board certified in psychiatry, family medicine, and addiction medicine. I want to say that I'm really happy to be here. Addiction is something really near and dear to my heart. You know, I've had family members suffer, and I spent many years treating addiction and studying addiction, and I really like working at the VA. The VA has been a fantastic place to work, and if you're a veteran out there that is looking for help, we're here to help you. We have a full service of therapists, psychiatrists, social workers, housing, residential programs. You're not alone. And just a couple things I want to say about addiction. The solution's super simple. It's stopping the substance. However, the pathway to that solution is very difficult and can be very convoluted and confusing. And that's where we come in. There's always hope. There's always hope in addiction. We see people get clean the first time. We see people get clean the 20th time. There's always hope. That's one of the reasons I love working in this field, because there's always a chance for a positive outcome, and not in a profound positive outcome. Something that where you can be suffering alone at the bottom, and then a year of recovery can change your whole life and create miracles. It's an amazing, amazing condition to watch. And there's a lot of wisdom in recovery. I'd like to say that some people in recovery are some of the wisest people I know. They have a profound understanding that the onus of control is theirs, that they have to make the decision every day if this is going to be a sober day or this is going to be a difficult day. And other people who don't have that challenge really never face their demons and have to make that personal change in such a profound way. And they have to do this oftentimes when they're young and when their life just starts, because it's a matter of life and death. Okay, that's it.
Well said, both of you. Thank you for the work you're doing. My name is Vesta Wunner. I'm the Healthy Moms Supervisor. We're an intensive outpatient and outpatient women's recovery program for pregnant or parenting women with children 5 and under. It's a perinatal funding stream through the Department of Healthcare Services at the state level, but it's run by Department of Health and Human Services, Behavioral Health, and we provide women assessments, group programming for intensive outpatient, such as if somebody's stepping out of residential. We provide 9 to 12 hours a week of groups. We offer free childcare, a breakfast program, and counseling, parent-child therapy, parent educational classes, substance use recovery classes, and cognitive behavioral therapy classes. Just a wide array of services, including case management, assistance with housing, and pretty much whatever the person that we're serving wants to do next. What are their goals is really our focus for helping them build the life that they want to create. And they often want to be reconnected with their children if they're child welfare involved, and they want to build back a life, go to school, or get a job. So that's a very quick snapshot of some of the things we do, and it's a great pleasure to witness women making those changes like the doctor just spoke to. So I will now pass it on to the chief of Rio Dell.
Derek, if we could mute the Zoom folks right now, that would be great. Thank you. Sorry, just talking to our IT folks.
Good morning. First, I'd like to thank the City of Eureka for putting this town hall meeting on. I'd like to thank Laura, Jacob, and the mayor for allowing me to participate in this specific town hall meeting. Again, my name is Greg Allen, and I'm the chief of police for the City of Rio Dell. As Jacob eloquently said, that we're a small department, 7 officers, but that's unique and where I still get to cover a shift. And so I am working the streets and seeing those that are addicted to substance abuse and that type of issue, have those type of issues. My career started going to HSU, which is now Cal Poly Humboldt, back in the 90s. However, I was born in Oakland during the 80s, which was the crack pandemic. And so it's very personal to me when we talk about substance abuse, personal and professionally. I've been in this field for 29 years, and to see those that suffered substance abuse and now seeing their kids have those same issues is pretty, it's heartbreaking. And at some point we have to break that cycle. And so I'll just leave it right there.
All right. Thank you, panel. So I think what we'll do at this point is we have a couple of seated questions, kind of ones that were written in, and we'll start with those. And then if anyone in the audience would like to come up and ask a question, we can do that after a few of these. The first question that we have here is, what are co-occurring disorders? And that I think can go to anybody, and we can have a conversation around that because that's a deeper topic, I know.
So a co-occurring disorder is any disorder that runs congruently with another disorder. When we're talking about co-occurring disorder in this capacity, what we're usually talking about is mental health coupled with substance use disorder. And why it's such an important topic is because each exacerbates the other. The mental health, untreated, will feed into substance use behavior. And then that substance use behavior will exacerbate the mental health and will very quickly and rapidly decline an individual's quality of life, which will often lead to more substance use, criminality, homelessness, and even death. And that's what co-occurring disorder is in this capacity.
Anyone else have any thoughts on that, or pieces that they would add, or the importance of integrating that knowledge into the treatment approach?
I would just add that it's really a key component of our assessment process when we're meeting with women, starting to serve them, is to understand the kinds of mental health symptoms that they're experiencing, because it's sometimes not just the substance use disorder, but chronic depression or other diagnoses that are impacting them. And if we can get them support in treating those, makes it a lot easier to manage that plus their recovery, and gaining understanding and tools that they can use to cope, I think, is one of the big parts. So I just wanted to speak to that.
So as a psychiatrist, we assess for both, and frequently they do come together. In the past, we would treat first the substance use disorder and watch the co-occurring disorder just fester. But now we treat them simultaneously. And that's so we try to, so if they have symptoms of depression, bipolar disorder, we usually get on board really early. And because, as Wes said, it's very difficult, to reach recovery with one not being treated. And another a myth is people often say I'm self-medicating, and and that may very well be true. So like they don't actually have a drug addiction; they're self-medicating a psychiatric condition. What I like to say, if that's the case, and you do meet criteria for substance use disorder, you actually have two problems now. You probably have depression and a drug addiction, so you need help with both. So, yeah.
All right, thank you. Do one more and then we can open it up to the audience if we have anyone. What is happening with fentanyl in Humboldt County right now as far as rates? I know this is a big issue, but if we can talk maybe about kind of how that's impacting the county and maybe the folks that you're interacting with on a day-to-day basis. What's going on there?
So I guess I can start with that one. First, I haven't seen a heroin positivity case in 2 years working the residential scene. And we do a lot of testing, which tells me one very important factor is that fentanyl is the drug of choice that is happening with our opiate users. Nationally speaking, what we're watching is fentanyl flood from East Coast across the nation. And because we are part of a national testing database, we're getting real-time data watching the analogs of fentanyl move from coast to coast. We watched 3 years ago as fentanyl was taking off in New York and the northeastern side of the United States. And we watched the heat maps of positivity start inching its way closer and closer across the nation. And then when it finally got here, it hit us. And we knew it was coming. And we were trying to prepare for what that meant for us because we had gotten really good at understanding opiate withdrawal and treating heroin use. There was a lot of gold standards in practice and some tried and true methods that we were all hinging upon our knowledge. And we thought all of that knowledge would really prepare us somewhat for fentanyl. As we watch the analogs, which is other forms of fentanyl, quickly creep up across the nation, we watched fentanyl come across. We watched parafluorofentanyl now moving its way across because the xylazine fentanyl is happening in the East Coast and moving its way here. So that's coming, folks, right? What we didn't know was just how difficult the detox portion of fentanyl was going to be. We didn't understand the lipidity, which means how it sticks to your fat cells. We were used to opiates getting out of a person's system within 3 to 5 days, which meant you could detox in that period of time if properly seen over. What we're seeing now is fentanyl staying in people's system for up to 2 weeks after their last use. Their detox is lasting 10 days. And we're watching people get kicked into precipitated withdrawal after 7 days of abstinence. It used to be easy, not easy, I won't use that term. It was common for us to convince a person to remain abstinent for 3 days and then get inducted onto methadone or Suboxone. And then that would transition the detox period comfortably as possible, which was an easy pathway to caveat someone into a recovery setting. Now we have to have people wait 7 days. 7 days of abstinence, 7 days of withdrawal and detox with no relief. And we have to hope that when we actually induct them with buprenorphine, that doesn't kick them into precipitated, which is worsened case of withdrawal and is very risky. So we have to change the way we treat. It used to be common practice at Crossroads. You'd get a grace period after you go through detox. You get a grace period before we pull you in and put you in regular group functions and daily functions. We'd be like, oh, give them the weekend, give them 3 days, and they'll be up and ready to go. Now it's the first 7 days of Crossroads before we even attempt to say, hey, let's get up and do some chores and get showers and do those things, because it's taking people that much longer to even begin to function. And that has changed the way we treat opiate use disorder. And we're watching it flood from East Coast to West Coast. So in case you're wondering what's coming next, it's parafluorofentanyl and fentanyl and xylazine, which is even more tricky to detox and has even harder overdose rates, because Narcan isn't working on xylazine, folks. And that's another factor that's happening with fentanyl, is it's taking more and more Narcan to reverse an overdose. I would like to encourage everyone to normalize carrying 3 or 4 Narcans with you, because one sufficiently is not enough. It's not enough, folks. So that's what I'm seeing with fentanyl. I open up the floor to anyone else.
Sorry, Chief Allen, can you speak into your mic a little bit more?
Let's try that. That better? Yeah. How about now?
There we go.
All right. Like I said, I'll double down what Wes said, and fentanyl is the drug of choice. I can't remember the last time I saw heroin as well, and we recently had an overdose, and the person had Narcan, but he didn't know how to use it. And so a couple of days ago, he had that case, and I kind of showed him how to use it because I know it's going to happen again. That person's not ready for treatment, and we have to meet that person where they are in their life. But we can encourage them to contact anybody when they're feeling like they're about to use. Methamphetamine is still out there, but again, fentanyl is the big one right now, and it's hard to combat it because there's always a new drug that's going to be more potent coming in. Like I said, the xylazine is coming in. I haven't seen it yet, but I hear about it. And where we hear about it is from those that are using. And they are our best experience and our best information gatherers, those who use it. And when you treat them like humans, they talk to you about their disorder. And that's how we get educated on, what we need to do to help them. So.
Any other thoughts on fentanyl?
Sure. Yeah, I can speak to fentanyl. So fentanyl is a high potency synthetic opioid, 100 times more.
Dr. V, do you mind speaking into the, microphone?
It's a high potency synthetic opioid, 100 times more potent than heroin. And all of our treatments are calibrated to heroin. So fentanyl is really setting us for a whirlwind. Our Narcan dosing, our Suboxone dosing, our methadone dosing are all calibrated to heroin. So we have this drug that's only been around a couple years, and we still don't have a good protocol. And we're trying, and the Bridge program at the hospital is doing great work. They are inducing people in the ER and at the hospital in that medically controlled setting where the precipitated withdrawals and other supportive measures can be managed. So that's kind of our best answer now. And then methadone can also be used with fentanyl at higher doses. And Suboxone works well too, but it's the induction that's really difficult, trying to get them off of fentanyl, as Wes was saying, and onto Suboxone. So, but there is treatment. It's just more difficult to use, and we're not up to speed. But there's hope. Yeah.
Thank you. At this point, I want to open up to questions from the audience. I see we do have one on Zoom. Maybe we can go to them. Las Coast Populace.
Hello, can you hear me?
We can.
Yes, this is Ash Teeter, LostCoastPopulace.com. I was just wondering, with the fentanyl, and I heard some of the presenters speaking about it, talking about how it's an east to west coast phenomenon, and not really talking about how it's coming, across the border from Mexico and being produced in China, from what I know. So It seems like that would be a part of a problem we'd want to, address. And then also just with the Narcan, from what I've heard on commercials and stuff, it seems like it's being, promoted as a solution to the youth without much, much talk of the actual, immediate dangers of the drug. I'm just wondering why there's not more just, facts on like how quick kids can die we see in commercials, instead of just talking about the Narcan for the treatment of it. And like maybe if kids were, hearing how quickly, or how just, just a fraction of a dose off could, kill them instantly, that might help reduce it in the youth. Yeah. And then also just, I know at the VA, we'd recently done a story on the like vending machines that are popping up that seem to be kind of like the needle exchanges, just like supplying, paraphernalia for drugs, and how is that, helping people in, supplying them with stuff to do it, and versus, other interventions. And also just the environmental impact of needles and stuff that we see littered around, whereas originally needle exchanges were supposed to be, exchanges, and you don't really see them being exchanged. You just see them littered around the county, causing a horrible environmental stuff. And will that be the case with other stuff that we're seeing, coming out of these vending machines? Is there any programs to, pick up this stuff that's freely distributed to people? And that's pretty much all that's on my mind. Thank you.
Ash, thank you. And just to summarize it, I'm hearing two questions in there. One, it sounds like you're wanting more information around like the purpose and strategy behind using Narcan, and then also the second question being the purpose and strategy behind harm reduction efforts. Does that sound like a way to summarize those comments?
Yeah. I guess that'd be a fair way to sum up my long-winded mega question there. But.
All right. Thank you, Ash. Yeah, let's pitch those to the panel now. Thank you. So I guess starting with the first one, can we talk a little bit about kind of what the strategy is for using Narcan? What is the purpose of Narcan? And then we can move on to the second piece of that afterwards.
I'll just talk about this is going to save your life in an overdose emergency right now. And as Wes was saying, you may need 4 or 5 of these if you have an opioid or synthetic opioid addiction or substance use disorder. Medically assisted treatment has a variety of drugs that can help somebody maintain sobriety over time, and that's not Narcan, that's methadone and Suboxone. And those are just like somebody who has diabetes, a medication that can help stabilize a person while they're getting other kinds of treatment and support. And some people need it ongoingly, like some diabetics need their insulin ongoingly, and some people are able to taper off at some point. So I just wanted to start the conversation. I'm sure there's some other people that have a lot of additional information.
Microphone.
Yeah, Narcan is a miracle drug. I mean, it brings people back from the dead, and we see this again and again. It's definitely not a solution to the problem of addiction. It's just a solution to death in the moment. So that same person the next day may go on and use, but they have another day to do it, and that's what we're giving them, another day. To your other question, harm reduction model versus abstinence model, was that it?
I think, what is the strategy behind harm reduction? And it sounds like there is a question around specifically the VA vending machines. I'm not familiar with this. So I don't know if that's a thing or not.
So, we do have a vending machine. It just showed up, actually. It's a topic of discussion. Harm reduction. So we tried abstinence models for years, and it works for some people, but it doesn't work for many others. And how do we save all those lives of other people who are not there yet? How do we keep them from dying? How do we keep them safe? How do we keep them, without getting horrible infections or spreading HIV or hepatitis C? How do we do this if they're not going to engage in an abstinence model care? And this is our best answer. It's not, there could be better answers, but we just haven't figured out a better one. It's messy, absolutely. But this is what we can do now, is meet them where they are, treat them with respect and dignity, help them, with their everyday medical problems, and keep them engaged in care, and hopefully one day they walk the path of recovery.
I would say that harm reduction model is a creation of necessity. What we have witnessed with addiction and substance use is we were using abstinent-based treatment like a mop, trying to mop up the tide. We could be out there all day long, but we're never going to make a dent. So harm reduction became the second most necessary step in order to help save lives and keep people alive long enough to maybe make the decision to achieve recovery. And one of the topics that I heard you discuss was the flow of fentanyl and how it's created and how it's brought to here and why is it such an issue. If we all understand fentanyl and drugs to be such a problem, why do we continue to see them on every street corner? And I would say to you this: if illicit drug sales account for $111 billion of our nation's GDP, what makes us think that we can stop something that is such a huge economic driver? We have to address that as a factor because our nation and our globe is very much entrenched into the economies of drug trade. And where there's a dollar to be made, it will be made. That can be seen with just about any other industry where we want to change things, but because it brings in $500 billion a year, we don't change it. There's plenty of motivation for it not to change. And there are plenty of people that are receiving those dollars that just view overdose deaths and disparities in communities as spillage and acceptable write-offs. So we have to really address our economic issues that drive addiction and substance use. I really like the title of this town hall, Substance Use Disorder, the Longest Pandemic, because it truly is a disease, folks. And as we all know, with how we treat disease in our country, we don't focus too much on the cure. We kind of just focus on what can be made from it. And right now, it is a thriving economy. And until we address the fact that this specific disease is a driving economy, we're going to be chasing our own tails for a long time, folks.
Thank you. I also want to throw out there too, in many ways, Narcan is a harm reduction method, right? I mean, it's particularly with avoiding people dying. And so, Ash, I think in some ways, kind of maybe those were one question, and that's my bad for splitting them. I think, if people are dying, we don't have an opportunity to get them treatment. And so we need to do all that we can to reduce the impacts of the use in order to get them to that point. And I think that was said very eloquently. Any other comments on that question? All right.
I had one caveat to add there. Just like when I was asking about, sorry I didn't get through when you redefined my question. It's just for the harm reduction, the strategy, I was mainly asking about how it was directed towards the youth, being that, a lot of them are coming into it they might not have used before. So coming at them straight with the Narcan, tidbits, would that, possibly, direct them towards using just because there's this Hail Mary that might save you, when propaganda directed towards them could instead be focused on the outcomes of fentanyl use and the death, the quick, imminent, possible death from it. And that's what I meant to ask them. Thank you.
Thank you for the clarification. So really, I guess adding a youth component to that. I guess phrasing that, are there harm reduction methods aimed at youth?
Well, public health partners with many entities throughout Humboldt County and the public school system in interfacing with schools around, having this be a topic, because many children are living in families where fentanyl and heroin and methamphetamine, and I can go on, exist. And kids share and trade. And so I think everybody's at risk. It's like a bleach in your closet. We're all at risk for these toxic chemicals. And so creating ways to talk about, what is part of our world, what exists. Drugs exist in our world. And there are, things that would help an overdose if somebody that you knew as a student came across that. And so I think it's sort of normalizing that this is an antidote for something that somebody could get a hold of. These synthetic opioids could come into anybody's existence. You could accidentally be exposed as a police officer or as a child in a school. I think people remember the Sunnybury Middle School gummy situation, so I think it's something that sort of exists, that it's important that we begin to talk about it and what to do, and each family has their own take on it, drugs and alcohol and what to do with that. But I think it is important for us to have sort of a community way of talking about it. And I know that public health works on trying to do some of that work in the schools and in our community to just create ways for parents to be able to talk to their kids about drugs and alcohol, and to explore ways to, cope if there is exposure. So I don't know if I've exactly answered the question, but it's a good question.
I think that's excellent. And Ash, I think too, a component of that education piece is a form of harm reduction. What we know though is that kind of doing a scared straight approach has been ineffective, as we saw with the Dare experiment in the late 90s and early 2000s. That ended up largely being ineffective. And so as a result, I think we needed to, out of necessity, Wes, I like your analogy of mopping up the tide. We needed more than just the education component. There needs to be the emergency piece as well to keep people alive long enough to help put them on a different path.
I have 3 children in high school right now, and they're uniquely positioned by proximity, by being the children of me. To understand addiction. But the way that it was posed to them, the discussion of Narcan, it's always been pitched to them as this is the tool for an accidental overdose. And there's education around the dangers of drug use. And that's the only thing I've seen come out of the school systems, which is, I think, a responsible way to do it. It doesn't insinuate that kids are intentionally out there trying to overdose or encouraging drug use. And it actually addresses probably the main factor of youth overdoses, which is accidental overdose. Most kids are going to get exposed to fentanyl by taking something that they didn't believe was fentanyl, by taking a pressed pill. They're not intending to go out and get fentanyl. They think they're taking a Vicodin or a Xanax. And in fact, it's a fentanyl-laced pill. And if they're not prepared to know what an overdose looks like and what to do in those situations, then kids die. So I think our school systems are taking a responsible and effective step in the right direction in educating our youth on what to do and what to look for and how to be careful, while also casting a certain amount of respect to substances, because they understand that there are extreme dangers to it. I hope that helps.
Thank you. At this point, I'd like to see if there's anyone in the audience who wants to come and ask a question. Yeah, come on up.
How's that? That work? Thank you for putting this panel together. My name is Gordon Clatworthy. I'm running for First District Supervisor. I have 2 questions, and first, I guess a little lighthearted jab. Probably the easiest way to destroy the drug industry here is put California in charge of legalization. It's just a... two questions. One, where can the normal, everyday person get Narcan in the community? It is a great tool, and I've seen overdoses myself. And two, what can the county do? With the caveat that, we're kind of in a budget deficit right now. But what are some things that the county can do to combat this? Thank you.
Any panel in any order?
You can acquire Narcan at Aegis, ED Bridge, any one of the programs. You can also go to the pharmacy. I do believe DHHS just authorized non-prescription orders of Narcan, so you can go right to Walgreens and say, I would like some Narcan, and if it should be covered by your insurance. I'm not quite sure on the exact out-of-pocket cost if it isn't covered by insurance. I haven't tried it yet, but I do know that if you ask somebody, you'll be able to find some. I would just say, knowing where to have some and being willing to hand it out when you have extra, you can actually come to Crossroads. I have a small supply I'd be willing to part with. And I do believe any individual that is prescribed an opiate these days is also supposed to receive a prescription of Narcan along with it. So any one of those ways you can receive Narcan. And what can our county do? I would say keep talking about it. Never let the conversation die. Never lose empathy, because we are a county of all people, not just some people. And our drug-addicted population, our homeless population, our mental health population, our veterans, we're all part of this community. Don't let us slip by the wayside. Don't forget us in the long run. And remember, we're all victims of this. We're all victims. And yeah.
Thank you, Wes. Anyone else?
I was just going to say public health is also another access point for Narcan. So you can walk in there and ask for Narcan.
I'll also add the city of Eureka recently finished becoming a distributor of Narcan as well, and we just received our first shipment of 20 cases. And we are currently working to put together a program to assist in getting that out into the community through Uplift's outreach programs and CARES outreach programs. And so that's going to be another source that folks can access it.
And the VA has Narcan as well. When you get a prescription for an opioid, you also get Narcan with that prescription. We also encourage anyone who's abusing any illicit substance to have it with them, because fentanyl is contaminating cocaine, methamphetamine, any white powder. It's cut on the same board frequently and contaminates those supplies. So it's not limited to opioid use disorder. Yeah.
Any other thoughts on? Maybe if we broaden out, not so much just the county government in particular, but what can our community do better to support efforts in helping folks get treatment or avoid overdose?
I would say become thoroughly educated on the resources available to our community. Knowing just how many programs and providers are all out there for individuals is super helpful, because I can't tell you how many times I come across an individual looking for help and they're only aware of one service or maybe two services, and they don't understand there's actually a large group of services they could be accessing. I also encourage the community to also be patient. It is not a quick nor easy path to get anyone into treatment, whether they be willing or not, whether there's an available bed or not, whether there is resources available for said service. It takes multiple things to fall in place for an individual to access these levels of care. I would say remain persistent. I would say find the contact information of these individuals at these programs and get to know them on a first name basis and communicate often, because it can be an entirely frustrating process where you try and try and try and feel like you get nowhere. But I promise you, the day that you do get somewhere and those doors open and that person recovers, it will all be worth it. So that's what I would say, is just become aware of what's available and remain compassionate, empathetic, and persistent.
Yeah, speaking from the medical perspective, be aware that there's a number of medications that are highly effective for substance use disorders. Methadone, Suboxone, naltrexone are for opioid use disorders and the long-acting injectable. And then we also have a bunch of medications we use for alcohol use disorder, which is still rampant and probably the largest problem in America to this day. And there's good medications for alcohol use disorder. I'm just going to say their names: gabapentin, naltrexone, disulfiram, camprosate, and Topamax. So these are all medications that any physician can prescribe. And so you can go to your primary care doctor and get these medications prescribed. They are, most are FDA approved, I should say, and they help with cravings, they help with sleep, they help with anxiety, they help with withdrawal symptoms. So there is, and they're highly underutilized, especially for alcohol use disorder, highly underutilized. So that is something that I see work every day in my practice. But the problem is people just are not aware that they're out there, especially for alcohol use disorder, and they never get the care. So that's out there.
Thank you.
I'll jump in. Is that mic working now? We good? Okay. From a law enforcement perspective, I think the county could expand like the city of Eureka does with their CSET program, MIST program. Although they deal with a lot of unsheltered and unhoused people, substance abuse goes hand in hand with that, and they're able to get them resources. And I think expansion of those programs through the county could help those that need that help, but unwilling or can't come to somebody and say, I need help. That's an avenue for them to actually try to get some help.
That's a really important piece, is the frequency with which law enforcement is the first contact for a lot of folks who are struggling with substance use disorders and homelessness. Yeah.
I was just going to add sober living for families and women with children is something that we really need. There's nothing here for that. And I work in another program, the Family Wellness Court, with Judge Abbey and Judge Heinrichs, and a lot of the tribal community is going to San Francisco for residential treatment to Friendship House. And so it would be really, besides Crossroads, great to have more residential treatment for families. And I just would like to see people not have to leave their community, because that's a real stressor to have to go away when you're getting clean and sober. So that's something that I've always wanted to see.
Thank you. Anyone else from the audience have questions?
Hi, I'm Linda Stansberry. I have more of a general request to the panel. I'm really interested in hearing more about your experience and knowledge of the history of substance use and abuse in our community, the different types of substances and that have gone in and out of not popularity, but use, and then a little bit more about some of the social factors locally that have made our population more vulnerable to addiction.
Excellent question. Thank you.
Well, obviously, our socioeconomical issues our high driver, our adverse childhood experience, our long-standing outlaw history of Humboldt County, our redwood curtain all contributes to some of our mentalities and some of the issues that we face. A lot of things have gone in and out of popularity. If you go back to the 70s, I mean, it was alcohol and marijuana. That's what we dealt with. That was what the normal was here. And then there was the push as industries started shutting down and certain organizations started getting into the black market marijuana trade, which brought other drugs along with it, which really introduced heroin and then methamphetamine. So when it all boiled down to it, you would see all four substances listed on just about everybody's assessment. It was marijuana use disorder, opioid use disorder, alcohol use disorder, and stimulant use disorder. Those are the big ones that we're seeing today. It is evolving. It is evolving because of fentanyl. Methamphetamine has stayed consistent. The numbers are not changing. They're not going down and they're not going up, which means it's staying. Alcohol still reigning, right? It is still the biggest problem. We talk so much about fentanyl because it's such a hot topic, right? And we see what it's doing, but we cannot lose sight of all of the substances that are having a negative impact on our community. We can't ever forget that it is all of these substances, the economies of these substances that are so deep rooted here, and how isolated we are. We've only recently joined a regional model that started expanding our services to the Northern California region, and really become operating at a pace where we're catching up to evidence-based practices. We were 10 years behind the gun for most communities. If you looked at Southern California, their best practices, their services that they'd implemented down there were light years ahead of us, and we've been struggling to catch up. And here we are now with all of the issues that are, some would say, very unique to Humboldt County, but in all sense, our story can be told in rural communities across the nation. And it is one of this propagated disease model of substance use continuing to spread and go untreated far too late. That's ultimate cost is human life. So some things are very unique to us because of our marijuana industry, our timber industry, and our fishing industries having their ebbs and flows, and now the change of our industries that we once relied on to thrive going away because the illegal trade has gone away, and now there is the permitted marijuana industry, which has caused lots of loss of income. And if you ask me, where does one cartel move to if they aren't able to operate in marijuana industry and now it's legalized? Does that cartel then just leave the area? Does that illegal operation just leave the area? Or does that illegal operation now switch to a different substance in which they can flood it with? So I think that's something that's definitely impacted us.
Thank you. Other thoughts?
Well, I really like that question because it has been something that's impacted our communities for a long time, substances. And even I'm looking at our stats for DHHS, alcohol is still the king. and tobacco use is also a real killer. It doesn't always get you right away, alcohol or tobacco, but in the long run, it can take you out. So, I think there has been a long history of death from those substances here. Probably over a couple 100 years, really. And then methamphetamine, and then everything else is kind of below that. And the synthetic opioids are now surpassing the heroin. So yeah, I think for me, just the antidote, besides these medications and ways medically, is the connection to community, that I get to see at Healthy Moms, which is women supporting each other in recovery and having a chance to get back to what they know is one of the beautiful parts of life, which is being able to connect with other caring people. So that's the most important thing, is connecting to your family and to your peers in a healthy way, and, you know, sharing food, sharing conversation, sharing childcare, feeling supported, getting a chance to process some of the things that have happened to you is sort of the beautiful thing of residential recovery and in our program and in life, when you can just say, gosh, it was a really rough day and here's why. Or I had a great success. I didn't drive down that street that I always went down to get my drugs, because I knew if I did, I'd go back to it. And I went this other way. And they're starting a new path. So I get teary-eyed, but that's okay.
Other thoughts on the history and kind of how things have evolved and come to the point where we're at? It's okay if not. I have a few follow-up questions. Vesta, I think you bring up a good point. We often hear about connection being the solution a lot, and I wonder if that social connection and the importance of that, if that could be discussed a little bit more amongst the panel, and how that factors into the recovery process.
You got one?
Sure. Okay, So when we do a psychiatric intake, we spend quite a bit of time talking about both their biological history. That means, you know, their genetics, their family, and their social history. Both have huge influencing factors on their on the risk factors, on their prognosis, on their ability to engage in care, and on their and how they respond to medications and to substances. So one thing we can't do much with biologic, you know, obviously that's inherited, but we can do quite a bit with social, and that's where a lot of our emphasis is at the VA, where we have groups where people connect with other veterans who are suffering from the same condition. We have peer support, where a person will come to your house and connect with you, because many of these veterans are alone and they don't have that connection. And without that human connection, it's hard to really have a vision of recovery and have a vision of what it's like to have a life beyond recovery. So you really need kind of that model and that connection to move forward. We also have therapists, and we also have social workers and outreach people. So all of that is our attempt to reconnect, you know, veterans with their community, with people, and ultimately, you know, back to a life beyond, you know, medical treatment and back to society. And veterans, I would say, are highly vulnerable. One is, oftentimes they see trauma, and that really disrupts their trust with people, the world, and with themselves. And then they have a substance use problem that also compounds that problem. So it takes quite a bit multidisciplinary effort and time to really, you know, reconnect and go forward. Yeah.
Thank you.
We should really ask ourselves, how does disconnect and separation from community actually occur when it comes to substance use and addiction? And then we look at the disease model and understand, well, what happens when we're dealing with disease or virus? Well, often the community responds with quarantine, right? You quarantine the sick away. And that is how we naturally treat addiction in our community. We separate ourselves from it. We see the behavior, we see its danger and its threat as a behavior, and we pull back as a community. We isolate them over there. The person over there feels that separation and isolation. And all that's left in that separation and isolation, of course, is individuals that have also been quarantined in their addiction. The substance then run rampant in their little mini communities that they build. So they build their own little communities where the substance use continues to be okay. So the disease continues to propagate, and they're over there isolated on their own, while the whole community now sees a growing population, a growing quarantine community, and then we see it as a problem, and then we respond with shame and judgment, lack of empathy, and then we continue to again go, you need to go there for treatment, go over there for help, go there. We don't view it as a communal issue. We understand it's a communal problem. We understand there's communal consequences. But the way we treat it, I can tell you just from Crossroads perspective, is you come inside our gates, you close the gates, and it's your own world, separate from the outside world. It's cut off. We feel like we're on a little island, and that's what people feel like when they enter treatment, is that they have been separated away until they're better. And that is the model in which most people view it as, is you have to get better because right now you're not good, you're not okay, you're not well. You're not ready to be accepted into society. And that's a hard thing to come back from when you have been ostracized by family and community so much for so long. And now you're told by everyone, well, as soon as you change your behaviors, we'll accept you again. It's hard for that to be the selling point when we've ostracized them so hard. So I would say, as a community, understanding that as a whole community, understanding that love is truly one of the big portions that we have to really start learning how to prescribe along with our medications and treatment practices. Drop our judgments at the door, because people are dying out there and they're not coming back to community. And often it takes many, many times through treatment doors to even put together long-term sobriety. We got to drop our expectations with folks, and we got to stop thinking that it's a grand scale solution. We keep thinking we're going to solve all of substance use, all of addiction. It's an individual journey. There are individual stories, individual successes, and individual failures. It's not communal. It's not something we're going to solve as a whole. We have to focus on the one person in front of us and not let them be so isolated that they don't ever feel like they could return.
I really like the way you said that. I brought this, I had worried about this talk, of course, as any public speaker does. So I grabbed from our childcare at Healthy Moms the toys, and it's like, these just kind of almost represent, people have to kind of put the pieces together in their recovery. One thing works, one doesn't, another thing helps, and you start to build your life back. Kind of like a kid learning how to use this toy, like they're going to practice living and exploring what works for them and creating their own treatment plan. I'm sure glad I got to use these toys, because I wouldn't have wanted to bring them all down here and not use them. But yeah, it is a process of discovery and connecting and feeling cared about and loved, and not feeling ostracized. I have another toy here, you guys, of just not feeling unaccepted in your community, like, go away, you addicts. And we all struggle, whether people have substance use disorders or not, in life. We're all trying to make good choices every day, with food, with paying your credit cards, like with money. We're all trying to find ways to cope and also enjoy our lives. And I think it's just really important to be more inclusive of people, better outcomes for all of us in our communities if we can look that way. And, a lot of times when the women come into our program, they sort of feel like everything has just become doomed in their life. Things are falling apart. Last visual aid it feels like this. And then by the end of the treatment, it starts to feel like they have all these directions they can go with reconnecting with their children, with education, employment, and their own self-care and connection to family and community. And it starts to feel really hopeful and exciting. So it's a pleasure to work in the field for me because of that. Okay, that's all I got on that.
Well, I didn't get to bring any toys, but I think for law enforcement, it's a different response. You know, we're called on a person's worst day. You know, we don't get called to the birthdays or anything like that. We're called when somebody's having their worst day, their worst moment in their life. And we're expected to solve that problem, something that they've been dealing with for, years. And so that's where we get into some issues of how do we make that connection. One thing about working in a small community or a small department like Rio Dell is we know each person who has those issues. And so we're able to bridge that gap and have a connection and actually talk with these people. And we don't have a time limit. When you have a busier agency, you're running from call to call to call to call to call. You don't have time to put somebody to give them the resources that they may need, whether you're just, they're under the influence, so let's arrest them and take them to jail and let them detox. Well, that's not really solving the problem. That's solving the problem right there. But when that person gets out, what is that person going to go do? Probably going to go get high again and go back to the same things they were doing before they went to jail. We're trying to do something different because we know that doesn't work. What we're doing is just filling up the jails with those that are under the influence. And we're not addressing the real problems of why that person is under the influence. What caused that person to start using drugs? Is it because that they're unsheltered, unhoused? Is it because that they had a death in the family? Those wraparound services is the stuff that we need to start addressing. And maybe, like it was said before, that this is not an overnight process. Those that have addiction problems are probably going to use again sometime in the future. And we have to accept that that's their story and be there for them and try to assist to get back on the right road.
Thank you, Chief Allen. And I wonder too, on that note, can you talk a little bit about CIT and the importance of kind of that model and how that can assist in providing extra tools to facilitate those conversations?
Right. And so part of CIT is, again, training. You have to be trained on, a lot of different things.
Excuse me, could you tell us what CIT is for people that don't know the alphabet soup?
Jacob, why do you put me on the spot like that?
Yeah, Jacob.
I'm sorry.
Go, Jacob.
CIT is crisis intervention training. So team and training.
So part of that training is learning how, one, to talk with people. If you notice that our new generation has a problem with communication, if it's not a text or a cell phone, then they don't know how to talk to people. And so what we're trying to do with CIT is being able to have successful communication with those that are experiencing some type of trauma, whether it is substance abuse, violence, or anything like that. It's a way to reduce the amount of use of force when we're dealing with people that are out on the streets. And I think that right now everybody's required to do 40 hours of training once they become a police officer. And I think that training helps a lot of people. It gives them some comfort, some confidence, and not necessarily going to all those tools on their belt where we're talking about guns, batons, and OC, pepper spray, and stuff like that, where you can use your voice and to talk to people. But you also have to remember that when we're talking about somebody that's under substance abuse issues or having substance abuse issues, that they're unpredictable. And so we want our people to be safe. And again, our number one goal is protection of life. And so we're talking about protection of life for the officer, the person involved, and the community. And so with CIT, that helps us be better prepared in addressing those issues.
Thank you. Another follow-up question, Wes, you had talked about the regional model, and we actually had a written question here. Why are there so many people coming from out of county coming here for services? I know about that, but I wonder if you could elaborate a little bit on the regional model and kind of what things were before and then how that changed to where we're at now.
So if we go back in time 3 or 4 years ago, we would all remember a time in which residential treatment was operating on its last dollar in our community. Funding issues were really creating a strain on the 3 state licensed residential facilities in order to operate and provide treatment. All of us had beds. We just didn't have the funding to fund them. So we were operating on shoestring budgets and skeleton crews in order to go through, and our county and our city was running out of dollars to fund them. The grants were becoming less and less. The county contracts were becoming thinner and thinner. And the solution to this was to find a way for state Medicaid dollars to fund residential treatment. Now, we'd witnessed in Southern California, the DMC, the Drug Medi-Cal Organized Delivery System, fund residential treatment in counties like Los Angeles. And so people with Medi-Cal could get residential treatment. Now, that wasn't the case up here in Northern California because we didn't have an ODS system. And that ODS system required us to have what was called a fully capable continuum of care, which meant that you had outpatient, residential, and detox all in the same county. So that way you could operate from all levels of care wherever a person may need to go. Some people only need to go to outpatient. Some people need to go to residential. You can graduate from residential to outpatient and back up and forth, but you needed an entire continuum. Now, we as Humboldt County had that. We had outpatient and residential and detox, but the rest of Northern California didn't. And in order for them to sign up to fund us in the same model, we had to create a population large enough to sign up. So we put together 7 counties all together, and that took a lot of doing. If you can imagine trying to get partnership and Medi-Cal cross-county to communicate and fund and refer and transport individuals and create a network of providers in this model, it was 5 years of just banging our heads against the wall, and we did. So, but what happened was at the end of that 5 years, the DMC model went live, the regional model went live, which meant that state Medicaid dollars would fund partnership to fund individuals stay in all levels of care from all counties. So individuals in Redding can actually access care here. And individuals in Humboldt County, if we don't have a bed, can actually travel to Redding. So they can go to Siskiyou, Shasta, Modoc, Trinity. They can go to whatever county has the service available, right? The problem that we experience is here in Humboldt County, we have 3 prominent residential facilities. So all these other counties call our county and say, do you have a bed? And in this model, we say yes. That's what we've agreed to. It's what we've contracted to. We don't discriminate based on county of origin, which means we don't give preference on county of origin. It's because we're beholden to this regional model, which it has pros and cons. I tell you, the individuals that can't get access in whatever county they're in, it's a miracle when they're able to hop in a car, drive here, catch some treatment, and then go home, right? Same way it's a miracle for someone here in Humboldt who's like, I just need to get out of the area to get treatment. I'm going to go to Redding real quick. It's a miracle to them. But that means that we are all running at capacity. Now, we used to think we had a lot of beds in Humboldt County when we would say, well, we have like 130 residential beds with detox beds in there. And we thought we were doing pretty good. You add 7 counties to that equation, and all of a sudden 150 just don't sound like enough. So we are all operating at capacity. And what that means is we are all fielding 7 counties worth of referral calls. Along with our own counties. We are all experiencing, on average, a 60-day wait. And what we are beholden to is not to operate a wait list. There's actually not wait lists within network providers. The reason why we built a regional model is because if I don't have a bed, you're supposed to be referred to the next program that does. So we're supposed to use the Carillon system, formerly known as Beacon, in order to phone tree you to all the counties and all the providers. But as we all know, if you run through the entire phone tree and everybody has a 60-day wait, technically you're on a waiting list somewhere. Yeah. So that's why I recommend getting to know the individuals that are in charge of the intake and in charge of the admissions of programs, so that way you can become, or that you can get on their call list. For instance, Crossroads, we don't operate a wait list, but I tell you, text me every Monday and Friday. Text me every Monday and Friday, and if you do, I promise you, when a bed comes open, if you're the person texting me, you're getting that bed. And that's this phone right here that I keep on me 24/7, folks. This is my 24-hour intake line. It's direct line to me. If you're calling a 445 number, that's a desk line. Don't call that number. It's the number on Google when you look up NCSAC Crossroads. Look up that number. Feel free to stop by. But that's how you can access care. And that's pretty much the same practice with every residential program here. Get to know the admissions coordinator and find the communication line that way. And that's what the regional model is. It's been a blessing, because now treatment is funded from top to bottom. The curse is that we all need to expand. We need more beds, and that becomes the bigger issue now.
Thank you. Other questions from the audience? I know there were a couple other hands, I think. Yeah, come on up. I'm not sure who was first.
I can be second.
Okay.
All right. I'm good. So, Elizabeth Rose Marini, I'm the VA Community Engagement and Partnerships Coordinator, which basically means I provide support to those in the community serving veterans who may not or are not connected to VA. So I wanted to add a piece of knowledge just to the general public, because access questions for things like how do I get Narcan were asked. Because I do outreach and education with other agencies. I work with a lot of them. So one thing that I know is throughout the county and in communities both large and small throughout the year, there are many public events, particularly if there's a health fair component. If you're looking for these resources like Narcan and safety tools for suicide prevention like unlocks or medication safety, please get yourself to some of those. Because most agencies here are making a real concerted effort to represent, to show up, to table with resources. Even if they hadn't handed out their last Narcan, if they're an agency that does that distribution, they will make sure you get some one way or another. If you're in a small community, you might look to your volunteer fire department, your librarian, or small clinic nearby. So just an FYI, there is access throughout the year in all these different ways. So if you need that, if you need connection, if you need resources, try and get to some of these. I mean, I've even seen some of the really large, public events like concerts and things like that, tabling by DHHS. I've gone to some of those. Other agencies have been present also. So they are out there. Look for them. Please take advantage of them. And then in the light of the discussion we're having about the need for beds, and I know budgets are an issue, and I know it's hard for people to say, yeah, I think we're going to do this, because nobody wants to be held to that. What do people present know about plans to increase access, to increase beds? I myself would like to know, and probably other people in the community as well. So if anyone has any info, please share.
It's an excellent question. Thank you.
Crossroads individual plan. I can't speak for HRC or Waterfront, but Crossroads individual plan, like I said, we are a 20-bed facility operating out of 2 homes on Myrtle. They have served us well over many years. Our current goal is to find a new facility that can more than double our bed space. And then, of course, use the current houses that we have now for population-specific treatment. The big leap is finding a facility that's going to meet the needs of a 40-bed facility. If you imagine what you need a facility to have, which is, of course, a commercial-grade kitchen and residential units and office space and meeting space and parking space in a community and neighborhood that the neighborhood actually agrees to, in a building that's going to pass inspection and is lendable. So the task ahead of me is pretty large, but in a dream world, Crossroads' big dream right now is to find that facility, if not build that facility, over the next couple years, and repurpose the house that we've known for so long as the Crossroads men's house to being population specific, and the women's house, and looking at parents with children treatment, because the houses, it's such a needed service. it's such a needed service, and what better way to utilize those spaces than to bring in single dads who have their kids who also need treatment, that don't want to give up custody of their children while they're trying to get treatment, and single moms who have custody of their children who don't want to give up their kid in order to receive treatment. Because I can't tell you just how incredibly painful it is to understand that in order to receive local treatment, you have to first lose your child. And I know that is, while it is a quick motivator, it is probably not the healthiest motivator for an individual. The amount of immense trauma that both child and parent goes through that process leaves individuals to feel unsupported in a long-term manner, that if you actually keep the family unit together, they feel wholly supported in their efforts and honored as a family unit, and not punished, and not using a child as a carrot on a stick. I understand that is the case in which we are at, and that's what happens in so many situations, but there has to be a better way, and we as a community should be able to provide that. So I am looking for the perfect facility, so that way those things can happen, because Crossroads has been the little engine that could for a long time. 20 beds is not a lot. It seems like a lot to me every day I clock in. But the truth is the community wants more. The community deserves more. And watching Waterfront grow in its facilities to see how much capacity that helps, understanding that that's the direction we need to go in our agency. We have a doctor, we have a nurse, so understanding that getting into the detox model is very important for our agency, because I don't know a person who goes through detox that isn't also looking for residential treatment. So being able to offer detox at our facility becomes vital and important. So getting our 3.2 designation to go along with our 3.1 designation, which means residential plus detox, just seems like the right direction to go. So those are some of the plans that Crossroads is doing. So if you see or hear about an incredibly large building going up for sale, just shoot me an email. Find me on Google, that's the plan of Crossroads. Thank you.
Thank you, and we'll definitely keep an eye out for you. Anyone else on things that are expanding more for more beds or more services going forward?
So for the veteran community, we contract with Waterfront for detox and residential treatment. We also have a number of facilities outside of the county, both VA facilities and community care facilities for detox and residential treatment. There's a lot of resources for veterans. There's lots of resources. There's also Nation's Finest, which is transitional living for 2 years. So we have the resources. Most of them are outside of county, so you'll probably have to travel, but they're definitely there.
Thank you. One that I'm aware of, I know Humboldt County Behavioral Health worked very hard to put in a grant, and were awarded, I think it was $12.7 million to with collaboration and support from many other agencies in the area to develop a triage center in Arcata on Mad River Hospital's property there. I know that will include a dual recovery treatment unit, as well as a substance use disorders treatment unit, as well as a crisis residential and a crisis stabilization unit. I don't recall all the bed numbers offhand. I know in total, I believe it was more than 50 across all of those different units, each of those requiring a different license. It's an incredibly complex project that they're working on. There's also the navigation center that will be coming here in Eureka, which is also a project that Humboldt County Behavioral Health is working on, and DHHS. And I know that's going to have, I believe, some beds that will be available. I don't know the details about what criteria is going to be needed to be met to access those beds, but I do know that they will have some. With that, I guess let me check. Are there any other thoughts or comments on that? Okay. I think with that, we'll take our break. So we'll come back and take a bio break for there's food and refreshments out in the hallway. There's also restrooms. We'll come back in 5 to 10 minutes here. Thank you.
So glad you're here. This is a great panel. What do you think? Yes? Yeah. This is fabulous information. And I think, this for me is one of the most important topics, and I've talked about people in the hall about this because it's the one that most people don't understand. We look at the legalization of alcohol and all of these things, and we think, oh, it's not a problem. And we look at people, and I loved how, I think it was, I can't remember, it might have been Wes, talked about, how we other people, like we keep them separate. And the truth is, at least in my mind, that connection is key. So again, we're going to thank you, and I'm going to turn it back over to Jacob. And I think we have one question already coming up. Janelle? Oh, Leah? And then Janelle. Okay. Thanks, guys.
Hey guys, I'm Leah Nagy, president of NAMI Humboldt, and I'm also on the waterfront board, so I see the best of both worlds, I guess you'd say. I have one question, and then I have a couple of comments. Does there exist in Humboldt County a youth detox residential program? And after you answer that, my idea, I'm wondering, is Sorrel Leaf going to have that component in its program for youth? Anybody know?
The answer is we do not have a youth detox program in a residential form. Any of those services are going to be referred to primary care and the emergency department in those situations.
Thanks, Wes. That's what I thought. Anybody know about Sorrel Leaf? I haven't really asked them that question. That's something we'll look into maybe. And they might have of course, if they deal with kids with mental illness and substance abuse, they're going to deal with it anyway, probably. So they probably will have something worked out where it won't be specifically substance abuse, but it would probably be a combination of the two. I just want to make a couple of quick comments. And Chief Greg Allen mentioned this, but the crisis intervention training in which NAMI Humboldt is part of a sponsor, and we do a family panel. And I thought I'd entertain you for just a couple of minutes, since we have some time here today, of a couple of family stories that will help you maybe understand the connection to the communities. And I appreciate, I was talking to Wes about, it's important for families to know who to call, when to call, how to get help. And as part of that journey, I offer support groups here in Humboldt County for family members. So I'm going to tell you a couple of personal stories. And as many of you know, I have 4 sons. I've lived in Arcata for 40 years. And the community knows my kids. One of them happens to have mental illness. And he has bipolar disorder, and he usually doesn't drink, he's never really used substances, but he doesn't drink. But when he has mania coming on, he uses red wine to calm the voices. And when I, as a family member, see him going into mania, and many family members struggle with this, you need to get them help, but they can't get help too early or they don't qualify for a 5150 involuntary treatment hold. So we as family members watch them slowly escalate into madness. We wonder, will they live through it? Wes mentioned death. Death is a real component of serious mental illness and substance abuse. Anyway, so I'm watching my son escalate into mania. He's got the red wine. So what do? I call one of my buddies, Pamela Millsap, which some of you know Pamela. Pamela used to drive my son's school bus when he was 5 years old. Pamela was one of my parents at Arcata Children's Center when her son Lauren fell and got hurt. And Pamela tells this story, how Lauren was on my lap and I called her. Anyway, so I call Pamela. So she goes over to visit my son, and she said, he definitely is, escalating. He probably will fit 5150 criteria. So she gets the sheriff out there. Well, they don't think he quite fits it yet. So this is kind of funny, actually. Not really funny, but anyway. So he's sitting in his front yard drinking, right? Singing, drinking. The neighbors are calling the sheriff back. The same sheriff that was there in the morning went back. Well, he doesn't quite fit criteria for a 5150 hold, but he's drunk. And instead of telling him to go back in the house and drink, they took him to jail. So Meanwhile, of course, I'm always out of town, you guys. I'm down. I think I was in Fremont, Fresno or somewhere. I don't know where I was. I'm always out of town. Anyway, so Pamela calls me and says, okay, they've taken your son to jail, but in 4 hours, they're going to release him. So I said, okay, Pamela, and I'm going to call the jail. So I call the jail. I get this great guy on the phone. I think his name was Jason. I said, Jason, you know, they've just arrested my son for being drunk in public, but let me tell you, there's more to the story. He said, oh, wait a minute. I think they're checking him in right now at the sergeant's desk. So let me put you on hold. I mentioned he has bipolar disorder, so Jason put me on hold, and he talked to the desk sergeant, and he came back to the phone, and he said, okay, we're going to hold him till in the morning when the mental health staff can assess him. Oh, my God. Prayers are answered momentarily. Then I call Cassie, and some of you know Cassie. She was supervising the jail. I worked with her at mental health as a CCT case manager. I say, Cassie, you know, my son's in jail. Okay, she said. So they assessed him, and of course he was not only drunk, he was manic, but by in the morning he had, you know, become not quite so drunk. So anyway, they got him treatment at Sempervirens. That's just a little story of how communication and families can really make a difference sometimes in the treatment of a loved one. The second story is pretty sad, but I have a grandson who was a wonderful young man and diagnosed with schizophrenia, used meth, got paranoid, committed a crime. He's now in Humboldt County Jail. I can't say enough for supporting the police, the sheriff, and the jail. Sometimes jail is the only way to keep our loved ones safe and to get our loved ones medicated. I visit him every Monday. I'm beginning to know the jail staff really well down there. I visit every Monday, and he is on meds. He's safe. He is not using drugs, and he is doing as well as he can in jail. He is the second Murphy conservatorship ever done in this county. And then we get on the list for the beds, waiting to transport him to a bed at Napa State Hospital or somewhere else. And Kelly Schwartz told me it's probably going to be at least a 2.5-year wait, which is sad that someone with serious mental illness, you know, but at least family members get comforted by the fact their loved one isn't on the streets and in danger of dying, which these folks do all the time. So I just wanted to share those couple of little stories with you, and thank you again for being here. Thanks to the city of Eureka and Kim for providing this. And I'm going to also send out on my email tree, because I have about 300 people that have done support groups, that they need to watch this on Zoom if they couldn't be here today. I think I've learned a lot of new things just by being here, so I'm going to encourage my family members to do that too. So thanks again, and thanks, Jacob, for all you do, and Laura for all you do. Great, everybody. Thanks.
Thank you, Leah. Any thoughts or responses or reactions to any of that?
Yeah, it's well, thank you for that story. I can relate. We have the same types of cases at the VA, people on conservatorship and suffering from serious mental illness. It's getting hospitalized level care is really difficult in this county, especially since COVID. California has a bed crunch throughout the state. There's just not enough beds. There's not enough long-term facilities. There's not enough psychiatrists. We're underserving this community again and again. Well, speaking on for the veterans in Humboldt, we do have wraparound mental health services for the seriously mentally ill. We have a team called E-Range that provides nursing care, in-home services, and social work support and medication management. So we can do the outpatient component pretty well, but when it comes to 5150s and hospitalizations and long-term care, that's much more difficult. Yeah.
I could speak to some of the barriers. and getting individuals access when it comes to it. When we're talking about our community, there are certain rules that you need to understand about accessing treatment when we're talking in specific to substance use disorder. And those rules are, remember, not agency made, they're state mandated. They are literally the law in which we're held under great scrutiny. And these rules are as follows. You can't remain an outpatient if you continue to use. You can't access residential if you're going to detox. And you can't access detox if you're currently loaded. These are the barriers that stop individuals from being able to enter same-day treatment. We run into these quite often, where an individual needs to wait 3 days to enter a detox, for detox to kick in. These are statewide issues. This isn't Humboldt County alone or any specific agency. These are statewide issues that we experience. You can't enter residential if you are going to experience withdrawal symptoms. If it's a residential facility, you have to then first go through detox and then enter residential. And like I said, in outpatient, you can't maintain drug use continuously in outpatient without needing to be elevated up. The problem that happens is individuals can't seamlessly jump between these systems of care because of our lack of bed space. When a person, an outpatient that needs to level up to residential, they need to do that today, not in 2 months, not in 4 months. And a person needs residential, they need it today. When a person needs detox, they need it today. And these are the problems that we run into. And we're held pretty closely to the DHCS standards and guidelines, and we are audited quite often, very thoroughly. And so we have to operate very carefully within these guidelines to make sure we're following that. We understand how difficult it is in these moments where someone comes to Crossroads and they go, "Hey, I heard you have a bed. Can I come in?" And I go, "When was your last use?" And they go, "Today." And I go, "Oh, shoot. What drug?" And they go, "Fentanyl." And I go, "Oh, shoot." And I go, "Are you going to detox?" And they go, "Yeah." And I go, "Oh, shoot." And I go, "Have you called Waterfront?" And they go, "I have an assessment set up for 2 weeks from now." And I go, "Oh, shoot." And I go, "Okay." And they ask me, "Will I have a bed in 2 weeks?" And I go, "Oh, shoot." These are all the things that we try to line up between different agencies. And what would be amazing is if we could seamlessly line up. We know that the detox bed is going to be open on this day, and my residential bed is going to be open on this day, and they're going to graduate and go down into a lower level of care of outpatient on this day, and have that all happen. But it doesn't. And we have not successfully implemented that across the board throughout this entire regional model implementation. We try really hard, and usually if you get anybody into any level of care, it's out of sheer luck, right? That's what we're all running on, sheer luck right now. You get someone in. I promise you it was because you got lucky and the bed opened up that day and you were the first person to call. So I really just remind people just to remember that there are certain levels of care that can always be accessed. Aegis can always be accessed. Methadone can always be accessed. Even if a person isn't actively off of the substance that they're using, they can still engage in systems of care, right? So making sure you're connecting people to those systems, super important, but to also understand, like, these are the barriers that not only you are frustrated with, we as providers are frustrated with. So understanding that is a big piece of information I would love to give out to the community.
Thank you. Any other thoughts? If not, I think we had another question. Or Vesta?
Just if anybody has, friends or family that are women with children 5 and under, pregnant, who need substance use disorder treatment and support, we provide that. We have our application on our doorstep. You can call. Counselor can call that person back if they have questions. So I just really want people to feel like you can access this if needed. There is the requirement of having partnership or Carillon. So you have to have that as your insurance to qualify, along with having a substance use problem disorder, So just want to make sure I said that.
Excellent info. I think we have another one from the audience that was kind of pre-planned.
Hello. My name is Janelle Laker, and my experience is amongst the homeless. My father was homeless. He was a mental illness alcoholic. That was back in the days when my mom called the police and was told that that's a domestic issue. And my mother said, well, I'm going back to get my 2 babies. And so if you come in about 15 minutes, you may find a crime scene. And when she left the neighbor's house, there was a sheriff's car sitting in front of the house. And she went in, and actually my father had left. And she got me and my sister and her other 3 children, and her went on her way. So law enforcement, I am a total support of law enforcement, and especially sometimes when they do things that may not be exactly to the letter of the law or whatever. Anyway, so, but anyway, I have also been spent time with homeless people that joined the Occupy, or didn't join, they were in front of the courthouse during Occupy. I was there in the evening. I did nighttime shifts when the Occupy was not a one group. And there were many people that left because a few of us said, no, we're not going to tell the homeless that they have to leave. So I was there in the evening and watched the da-da-da-da. And there were people with mental illness there. Without telling you the stories or anything, I can just tell you that there were people. There was one incident with a person where it hit the news, and I tried to contact the person. In fact, I contacted the reporter and said, that gentleman has a mental illness. He comes up and he yells at me every once in a while, and I respond to him, and he goes back and sits down. He has a mental illness. I know I've had individuals that I have tried to help, and giving rides and that type of stuff. And in one case, I watched her go to the MAC, even though she did not. It was her choice between going to the MAC or going to the Dell's playground. And she did not do well there. That's all I can say. She needed a place to live. Those are, never mind. So, I was also at the sleeping sites. I was at the playground. I mean, when they had the thing at the Dell playground where they designated that area. And I was there. And again, there was all different approaches to dealing with that. And I was requested to go. The attorney, I'm in the civil liberties issues, and I was requested by the attorney that filed the lawsuit to show him he had been given the name of somebody to go talk to. And I went, and they hadn't. We first came to a first campground, and they did not want anything to do with the lawsuit, or he didn't. And I said, well, because he was saying, well, we can get you a few $1,000s at least. Even if we don't win, we'll get you a few $1,000s. And I said, well, what if the lawsuit was to get a campground? And they said, yeah, we'll do that. And I feel guilty about that because they couldn't get a campground up, but it got them, it got, folks to sign up. And they needed to be sued, I'm sorry to say. And I can also tell you a story that I went down to the hearing, and another advocate went with me. And after they had done the court thing and the judge was going off to write his order, she tapped me on the shoulder. She said, she's crying. She pointed to the city's attorney. And I said, oh, no, she's got a cold or something. But then when I turned around and I looked at her and I thought to myself, if I had to say what she just said, I would be crying too. Because the argument they gave to the court was that they had enough places for every single person in the Devil's Playground, but they only had 11 plaintiffs. So the order only reached to those 11 plaintiffs. They could evict everybody else, but they had to provide housing or place for those 11 plaintiffs.
I'm sorry to interrupt. I do want to make sure that we get to something that we can discuss. I appreciate the context.
I'm sorry.
Okay.
Thank you. Thank you. So anyway, what I'm trying to say is that I come at this issue from a civil rights issue place as people need a place to live. And that's where I've been, and that's what I'm doing. So regional. There is now, there has always been funding. It's called, whatever the initials are. There's always been funding for, that has been used to build housing. And it could have been used, it can be used for interim housing, There's also laws that, I don't know how to explain this. I'll just go cut to the chase. We could do campgrounds. We could do a regional system of campgrounds to address homelessness. That's what I left out. Oh, I did too. And I said, and this would be a place where people could live, and they could live But the kicker is that the continuum of care and the governmental agencies have to want to do this, and they have to ask and present a proposal. It's not like, because the state and everybody is focused on building housing, which is, of course, very, very important, because you need housing. So before I end, so my question is, would you support that? Do you have clients? Do you know people that would need this and could use this? And regional, it needs to be regional. So again, as much as you need regional, the dealing with the homeless issue needs to be a regional approach. I think, was there a question? Yes. Would you support this?
I was just going to say, just for me, supportive housing with the women that we work with RCAA, Redwood Community Action Agency, helping women get housing and then helping them save for permanent housing is really helpful in early recovery. That's kind of the way I come at it. So funding to have supportive housing so that people can, but housing in general, huge need, support it. We need to advocate for it legislatively. That's all I wanted to say. I know it's 1:00, so.
I wonder if a piece that we can add to that question is maybe the importance of the housing first model as it relates to recovery and substance use. Does that?
Well, yeah, I guess speaking to what he was saying in terms of building a new facility, building facilities is housing. You're going to find that there, I don't know, hopefully you have a different funding stream is all I'm going to say. And it's also in terms of land and all that is that we need housing. And as much as I know you need that, I guess that's what I wanted to say is, are you familiar with Sam Simbaris, the Housing First model? he used housing in the community. And so that's a model you might want to look at. And in terms of you trying to find housing for women and their children, there were women with their children that lived in were in the campgrounds. And that was one of the reasons their children were taken away, was because they were living on the streets, and you know that. So you need housing for them so that they can keep their children. And you are competing with all the, the social workers that need housing also. Thank you.
Thank you. So I wonder if maybe commenting on or discussing the importance of housing first and maybe some of the barriers to putting that forward. I know there's often a lot of talk around housing first. And unfortunately, sometimes that gets implemented almost as a housing last model where people get housed and then we don't provide the other treatment. And it's definitely not the way to go. But, housing first as an evidence-based model definitely is important. And I wonder what are maybe some of the barriers to that here in Humboldt as it pertains to substance use treatment, and how can we help improve that?
Well, I would say that 99% of all residents of Crossroads are chronically homeless. When you arrive to residential, that is the first thing we treat is the homeless issue, because we are now providing shelter. That's what makes the residential model so robust, is the fact that it's providing the food, the shelter, and the community all built in. That's why it's highly sought after. We serve individuals for 120 days, and then it becomes our issue to find the next level of housing. What we have available within individuals that have barely even began to establish income, or are very low income, or still no income upon graduation, the options are slim to nothing, because it's clean and sober housing, and that's just another multiple bed house that individuals go through for about $500 a month for their bunk bed, and those remain full as well. The great thing about clean and sober housing is it's not specific to individuals with substance use. People that have no substance use also utilize them. But the fact that that's our only option it's a crime as far as we're considered, because we're not doing a big enough service. Finding places for people to live is a problem across the network, across our community, and it is one that, if we properly addressed, would actually relieve a lot of the tension and pressure on our current model. Because if the residential portion were available to individuals, then they wouldn't always have to seek residential care. They could utilize outpatient care more often, you see. But if you're homeless and addicted, then you need residential, because that's where the residential portion comes in, is the shelter. If you have a place to live already, then you don't have to overutilize residential. You don't have to elongate your time at residential and do 120 days or even longer because you can't find housing. And if you have a place that can give people a safe place to be, then you don't have to worry about where people go after, or where they are in the meantime waiting for these treatments. It is something that we really do have to look at, and we have to get creative, because we can't just build one house or 10 houses or 100 houses and think we've met our goal. We have to do things that are far, far more creative, because individuals aren't always going to access our standard idea of what housing is. And the idea of campgrounds and safe spaces and small and tiny villages, these ideas are out there and they've been implemented and they work, but yet for some reason we haven't done them here, for multiple reasons. But we do need to put a concerted effort, because we will continue to lose people on the streets and watch people suffer. It's not just a substance use issue. Too often people think that homelessness equals substance use and substance use equals homelessness. I was there at the Devil's Playground eviction, the leading up to time where we were trying to offer services, and because we were a residential program, we thought, we're going to be out here and I at least have beds. If you need a place to go, I have beds. And I was not shocked, but surprised that the vast majority of individuals that came out and said, what service do you offer? And I go, I'm Crossroads. It's residential drug treatment. They go, oh, I don't have a drug problem. And they weren't lying. They weren't lying. The people that were coming out, they were homeless. They weren't drug addicts. They were homeless. And in order to receive my care, you had to have substance use disorder. Like, that became a barrier. The actual service I provided became a barrier to help anybody coming out of there. So if that helps people understand that this issue goes beyond just having substance use treatment, but it is a housing issue, it's an economic issue, it is a generational issue, it's a communal issue, it's systemic, it's statewide, it's nationwide, and it's global. There is a vast network of individuals out there that do have resources. We just need to figure out how to match those resources with the doers and then convince our community to allow it to happen. And I do agree, land and space is where we need to start.
Thank you. Other thoughts?
I'll jump in. I'm all for giving people housing. I think one of the issues that we have to do is also give people life skills. Somebody who's been homeless for 10 and 15 years, and now that you give them a home, they don't know how to live in that home because they've been used to a certain type of lifestyle. And I'll give you an example. I went to check on a homeless guy who had just got an apartment, and that person had a tent in the bedroom, and it was destroyed, and it's a brand new apartment. And so if we're not addressing some of the other issues, the drug use, the mental health issues, life skills, we're wasting that person's life right there. We're wasting resources because we just put this person in a situation where that person is not going to succeed. And so if we're trying to help this person, then it has to be a wraparound. We can't just provide somebody with a house and say, there you go, and expect them to be successful. We have to offer them other services so they can learn how to live in that house, how to access services, and be more responsible for themselves and their actions.
Absolutely. I think, Raphael, did I see that you had a question back there?
Hello, folks. Hello, panelists. I'm Raphael DiCaprio. I am a substance use navigator. I'm also a certified drug and alcohol counselor. I work at Providence St. Joe's emergency department, also Redwood Memorial. I wanted to talk about, go back to Narcan. So Providence, Redwood Memorial, and St. Joe's are now 24/7 Narcan distribution sites. Anybody in the community can come, no questions asked, and get Narcan in our emergency department. Like was said already, I recommend 3 to 4 because the fentanyl is so strong. And yeah, so anybody can come and access that. We do like to refer people to the Wellness Center. That's where they can also get Narcan too, as well as Aegis. I do a lot of presentations in the community, and I wish I had my PowerPoint here. One of the most powerful images that I start the presentation with is a picture of someone behind bars, and it says substance use disorder is the only medical condition that's also a crime. And that's so true. A little personal history. I am a person with substance use disorder, long-term, in remission. So the stigma is very, very, very real for me, and that's what drives my work. A lot of people that I have known are no longer here because of fentanyl, and so it's really really near and dear to my heart. So I agree with everything that's been said here today. I really want to I love what Kim Burgell has been doing, and the county. I really think that we need to put our heads together, and we do need to find ways to help folks get into detox, get into treatment, because it's just so hard and difficult. Our principles for the Bridge program, and that's what I coordinate at St. Joe's and Providence and Redwood Memorial, is the California ED Bridge program, and anybody can come in as long as they're in withdrawal and receive medication for withdrawal with either buprenorphine or if if they do have alcohol use disorder, then we can treat them with medications for that too. And they can come in, and hopefully once they get inducted, we can continue them into treatment. So what that means is we connect them to the Suboxone clinic in their local area. So it's first a low barrier treatment, then connection to care, to services. We just don't give them Suboxone and then they're on their way. We make sure that they have an appointment, and we check in with them. We follow up with them. If they need help with transportation, we offer those services. Because opioid use disorder is a medical emergency. And now that fent in all is in everything, substance use disorder is a medical emergency. And we are just scrambling because it's very, very difficult to get people into detox. We work very closely with Waterfront, and Dr. Bayan has allowed us to do assessments for Waterfront to help out, and even that is, not enough. So I'm looking to the city and to the county and to our wonderful panelists and our leaders, if we can put our heads together and figure out a way. We either need another medically managed detox or a social model detox. We need somewhere where these folks can go. And I know it's there's been some talk about it, but I think that we really need to revisit this. That's where we're at right now. Anyway, thank you so much. I'm so grateful to be here.
Thank you. It brings up a question that I kind of have in talking about, the difference between a medical detox and a social model detox, and the different withdrawal states that can occur from different substances. And I wonder if maybe someone or a couple of the panel could talk about which withdrawal states are fatal and which withdrawal states are, require more medical oriented intervention. Because I think that's really important information for folks to have out there, especially if someone is considering stopping using a substance, kind of being prepared for what some of the aftermath might be from that choice.
Sure. So alcohol withdrawal can be fatal. And that requires medications, usually to help with the withdrawal, detox medications, benzodiazepines, and antiepileptics. That's something you can do through outpatient care, ER, or even a detox facility like Waterfront. Benzodiazepine withdrawal is something that requires medications and support as well. And again, usually outpatient care, detox, usually not in the ER because it's a long withdrawal process. And then opioids are considered not fatal, but very uncomfortable. And the risk of relapse is super high. So you definitely need support and assistance, especially with fentanyl. And you can get medications, through the bridge, through outpatient care and through residential detox like Waterfront. Methamphetamine detox is considered not fatal, and that's usually a crash, dysphoria, sleeping. It's everything. Yeah, so detox and withdrawal is the opposite of the high. So if methamphetamine stimulates you, you're going to experience the low, for days, and that'll be hypersomnia, where you're sleeping a lot, feeling really down and out. Yeah. And what else is there? Cocaine's also not considered fatal detox. Yeah.
I think the other fatal one, and I don't know that it's seen much anymore, is barbiturates. Is that correct?
Yeah, that can be fatal as well, but that's I don't think I've seen that. Yeah, I don't think I've seen that. Yeah,
it's issue from years ago. Yeah. Not so much now. All right, thank you. A couple times today, and just looking at our time, maybe this, depending on how long this goes, maybe this will be a discussion to kind of wrap us out. Stigma's been brought up, and the difficulties accessing treatment because of the stigma that people experience and that othering effect. as it pertains to people who are using substances, but also, some of the kind of co-occurring, states or I guess categories that people fall into where, homelessness is a problem or mental health issues are a problem. What can we do as a community to help reduce stigma, for all of those, but specifically for substance use disorders, so that we can eliminate some of the barriers of people asking for help, and getting into treatment?
What a complex question. I think it has to begin with humanizing the individual in the public's eyes. It has to be a empathetic campaign to get the community on board, because it's the individual that has been othered is not going to do the work to change our minds, right? We have to start within. We have to work within our communities, our schools, our churches, and we have to push out the idea that the work is going to be on us in order to change that narrative and to create a welcoming space, which we know is going to be difficult, because the problem with substance use disorder and homelessness and all of these issues being wrapped together is that everyone feels that they are the victim of it. And there are several different responses to take when you feel like you are the victim of something. The community wants to be angry at it. Families want to be hurt by it. And it's asking those individuals to look beyond that hurt and pain and see the individuals as human beings, maybe even view them as yourself, and reach out across the aisle, pull in, have the conversation, ask the questions, do the thing that's hard to do. And you might find out it's actually a lot easier than you think it is. It's easy to separate the community if you don't view them as someone who is an equal to you or an individual on your level. It's super easy to do it. Like, oh, I would never let myself get that bad, or I would just pick myself up and I would go seek out help. And the problem is everybody that's sleeping on the corner or using drugs said the same thing to themselves maybe 10 years prior. I would have said to myself, I remember being like 12 years old telling myself, I will never use drugs. Drugs are for losers, and I won't never be a drug user. Fast forward 1 year, and I was using drugs. And I had a long history of using drugs. And I was very isolated from the community. And it took a community coming to the hotel that I was staying at, reaching out to me, inviting me in, and checking on me every week, and calling me on my BS when I had BS, in order for me to get my feet planted on the ground and to buy into this idea that recovery was worth it. Fast forward it 10 years, and look what I do now. That was because a community reached out to me. It wasn't because I did anything, folks. All I did was stop using drugs. And that's the story most individuals that are successfully in recovery. The work that we did was just stop using. The community is what wrapped around. The support is what wrapped around. So we need to remember that it's all our jobs to heal people. And I know it's a big job. It's my full-time job, and it bleeds over into after hours and the weekends, and ends up leading you to talking in a city hall, a place you never think you would be. It's a job, folks, and I know it's tiring, man, but we can't give up, and just reach out.
I just wanted to add to the question, or maybe just point out something that I hear often about substance use, and that is that substance use is a choice. If you wanted to stop, if they wanted to stop, they would stop. And I was hopeful that we could include that portion in the conversation, because as many of you probably know, after the first drink, maybe that was the choice. But after that, I think that, oftentimes addiction, you lose power over the second one. So if someone could speak to that as well. Thank you.
Substance use disorder follows a disease model because it behaves like a disease. That's why we say it and repeat it over and over again. This moral failing issue, sure, it feels that way. Sure, it feels like it could easily be that way, because then we get something to blame, right? an individual's morals. But the way substance use disorder works is first you're predisposed to addiction. Say some adverse childhood experiences occur in your early childhood development that leave you to heavy cortisol responses, which means you're constantly in fight or flight. Your dopamine production is naturally lower. So then you'd learn how to survive childhood on those parameters. And then one day you get old enough to where you're exposed to, say, a stimulant, a heroin, or an alcohol, and then you utilize that substance. And then all of a sudden, for the first time in your life, your brain responds with a dopamine production that you never felt. And then for the first time in your life, you feel like maybe I can be okay. Now, your dopamine production doesn't work properly to begin with when you're in those situations, but now you're flooding your system with dopamine, right? You're now flooding it with 10 times, sometimes 100 times more dopamine than you're supposed to produce. Then you become reliant on that chemical for the dopamine production, that it becomes part of your daily process. So every day you wake up, in order to feel okay or feel okay, you have to use your substance. So you repeat that process day in, day out for years, to where you have now hijacked your brain's reward system, where the thing that brings you motivated, right? The things that all of us brings us motivation, right? I get up motivated to get up to work. I'm motivated to eat. I'm motivated to relax. It's dopamine that motivates me to do those things. I get dopamine when I go to work and I have a good day. I get dopamine when I drink a cup of coffee. I get dopamine when I see a good friend. Those are what motivates me to do things. Well, guess what? If substance is the thing and the only thing that is triggering dopamine production in an individual's life, they become dependent on that substance. And the worst part is, once you stop utilizing that substance, dopamine production slips to dangerously low levels. And then that's where the deep depression comes in. That's where the dark thoughts come in. That's where the loneliness comes in. That is why we say it's not a moral failing. It is a brain disorder, and it follows the disease model because it behaves exactly like a disease does. It is spreadable, it is communicable, and it is curable with treatment. And that's what makes it different.
Other thoughts on that or the stigma component?
Yeah, I'll add in. I think Wes hit the nail on the head when you're talking about humanizing. And you start that within your own department, your own agency. And he also mentioned that, looking down on somebody, thinking that you're better than them or they're less than you. I always tell people that, one decision in your life could have put you in that same position. And so think about where you came from, the people around you, and those that are suffering in your family, and put yourself in that position. Humanizing is a great way to understand what somebody else is going through.
Other thoughts?
I just wanted to, plug that for people that aren't active substance use disorder people who have those issues, getting support for yourself is also really important, Al-Anon, community, NAMI groups, ways that you can advocate for housing first, participating in something meaningful to make a change and be an advocate for our community is really a powerful way to take action. So I'm just really happy to hear the audience's stories and see how people are involved in creating community that will help everybody, not just, a program or a person, but a whole community with housing. And so thank you. And I'm sorry, I thought we were done at 1, but it's 1:30. So I apologize that I was bringing up time when you were talking there.
All right. Any last thoughts on that question or any other topics that we discussed today from the panel?
I had something if there's time.
Oh, sorry, Ash. I think we're right at about time, and I want to leave some space for closing. So I think we're going to wrap up the questions and just kind of leave off with any final comments. But if you want to email the question to townhall@eurekaca.gov, I will be able to get that, and then we are going to try and have a follow-up video, especially since Dr. Byen couldn't be here today, and maybe that's something that we can run by the by Dr. Bine in the follow-up video.
Okay, thanks.
Thank you. Any final thoughts? I super appreciate everyone. Oh, sorry, Wes, where are you going to go?
Oh, I was simply going to close out with, I know sometimes this subject can seem super overwhelming, and it can seem like there's not a lot of hope in sight, and it can seem like our community is specifically affected disproportionately, which can all be true. What I will say is this, while our problems run deep, so does our community. We are stronger together. And I tell you, for as much stuff that we've seen out there that are barriers and obstacles, we are full of individuals that make way and have solutions. We are strong, and we are more passionate than I've seen in any small community. No matter what our differences are, we come together for solutions, and I believe that we won't stop until we have a system that works better. So I just want to say thank you to the entire Eureka community for continuing to support all of us, all of our other agencies that we come together to collaborate, because for a tiny little city of Eureka, we sure do have a lot of folks and programs trying to do something to make a difference here. So thank you, all of you, from the very bottom of Humboldt County to the very tippy top, all of us together stronger, folks.
Can I jump in real quick?
Absolutely.
Thank you, Jacob. Appreciate that. Again, I also want to thank the city of Eureka for hosting this, especially down in the city of Rio Dell, where we're limited in resources. So I met Raphael, Melissa, Elizabeth. Yes. Okay. Got them all three. Resources. And so networking is very important in a small area like Rio Dell, and then we can provide some services down there to the people that need it. So again, thank you for having this collaboration in this forum.
And just one last plug. I just want to say there's always hope. You're not alone, and there's good treatment out there.
Thank you.
I guess just what he said, that there is help, and please reach out if you or somebody in your life needs that. All right.
Absolutely. And I'd like to thank our panel for being here today. Is excellent discussion and conversation. I'd like to thank our audience for spending the morning and early afternoon with us, and our folks who came and tabled. I think there was excellent information shared. I can't understate the importance of the community component, and I thank all of you for hitting that nail on the head so many times over. I think that's so crucial to working on this. Humboldt is a small county, but we have a really remarkable amount of services that are here. Unfortunately, sometimes we're a little siloed, and I think one of our biggest challenges is just finding creative ways to come together and work together, because the more we do that, the better service array we can provide. Recovery is possible, especially when we're all working together. So thank you, everyone. And then I'll hand things off to Mayor Burgell to close things out.
Thank you. I too want to thank the panelists. This has been a very, very, very robust and important conversation. And I appreciate everything that you brought to this conversation today. And I hope that this continues to carry on, because, I think, and I believe this 100%, that a healthy community, we lift each other up. We work together in collaboration to grow and to support each other, regardless of our station in life. I think that's critical. And I just want to appreciate the audience that we have here today. A couple things that I just wanted to say was that a couple of things were, first of all, this thing about, asking a better question. When we hear people's stories, when we know where they came from, we certainly have more compassion for them. And being willing to have that opportunity to listen to people, I think, is critical in this regard. It costs nothing to be kind. So if you can't do anything else, don't say anything and just smile. And then lastly, if you're using, or if you know someone that's using, you're not alone. There's a lot of people in the community that want to help and support you. It's not a moral issue. You're not a horrible person. You have an illness, and that illness can be treated. And there are lots of opportunities to do that. And you can reach out to any of us for that support. So with that, for family members, there's Al-Anon, NAMI, those kinds of things. I just really want to appreciate our community as a whole and the city of Eureka, because the city of Eureka is really focused on solutions. And I think we are as a region, but I really appreciate the work that's happening in our city one day at a time. So with that, I would say that I think that we're done. Again, I can't appreciate you enough, and I hope that we can continue these conversations. So happy holidays. We're done. Thank you so much.